Majority of the palliative care centers in India are situated in cancer hospitals. But this is a tertiary hospital which sees both cancer and non-cancer. So we are now trying to address all the palliative care needs in patients with non-cancer condition. It could be patients with chronic kidney disease, patients with heart failures, patients with end-stage lung conditions, critically ill patients who are not getting better in the ICUs. All of them need palliative care. And this is our focus area that we are doing, which is probably different than other palliative care centers across India.
They are very specifically, the cousin brother has said don't disclose anything to the mother also, because she was very distressed. The father was saying that give her some time, she's keep going and talking to her every other time, she's crying all the time.
KMC Manipal has been involved from the CTC 3 when I came in, and we have been able to mentor a lot of institutes, provide that hand-holding through setting it up, and then later Dr. Naveen Salan sir has been involved in auditing their services, whether they are able to meet the standard requirements, and also helping them meet those standards overall. So it has provided an academic input, a mentorship, as well as there are a lot of colleges who are into the CTC program. The staff has come in here to take a hands-on training with us, so they observe how our department works, how our functioning is, the kind of patient population that we are seeing in. As we have integrated not only in oncology, we have also gone beyond into renal supportive care, ICU palliative care, pediatric palliative care.
Palliative care is one of the most neglected areas pan-India.
Even during our training, we are not trained for managing the patient who needs palliative care. From the beginning, maybe our initial days, MBBS, MD days, I think this training or this specialty should be integrated from the training.
Before the introduction of palliative care, we were actually taking care of all the palliation and the pain aspect of cancer. I think what exactly happens in mainstream medical oncology, or when we are seeing a patient, we tend to ignore a lot of symptoms and the side effects of the treatment.
If I look at other centers in our own state, a lot of them are not fortunate enough to have it. So, the radiation oncologists themselves have to undergo significant training for opioid prescribing or even storing or procuring. And procuring morphine itself is quite a challenge. And so a lot of patients are not given good pain relief and don't have access to these medications. Secondly, a lot of times when they are metastatic, futility of care or those end-of-life discussions become very difficult for busy clinicians. And if they don't have the palliative care physicians integrated, often patients end up going to the ICU and dying in the ICU rather than dying at home in the comfort of their care. So that, I think, is not uniform. Not a lot of places have that very well established for them.
I have been in the healthcare industry as a hospital administrator for more than 30 years, and I've always felt that there has been a gap when it comes to palliative care. The doctors typically felt that they need to keep treating a patient till the patient dies despite their efforts. They used to say, if I feel that I cannot cure you, I lose the right to treat you. It has been a debate globally on what constitutes futile medical intervention. So this has been there for a long time. So we felt that being a teaching hospital here, one of the premier medical colleges of the country, we felt that this is a good place to start. And I got the opportunity to make that start when I came here as the Chief Operating Officer.
So one of the challenges I always felt is, a country like India where you have data by ICMR which shows about 6 million people every year in need of palliative care, but hardly 2% of the population have access to this. And many of these patients who had no recovery or no chance of recovery, die with a lot of sufferings. And at times, the economics come into picture. So this palliative care has helped a lot in handling these kind of situations where they could discuss with the family. We could, in fact, inform the family about the prognosis, about the cost, and also that families can take a decision. At the same time, provide a good quality end-of-life care. So that really helped us a lot in managing the hospital. And as a medical superintendent, it personally helped me a lot in managing our ICU beds in a much better way, and probably providing ICU beds for those in great need of ICU care.
My experience with palliative care, actual experience starts with my parents who were admitted to KMC Manipal. And both my parents, father as well as mother, they were treated for end of life at the hospital here. My father died in the ICU, and it was not the best of experience. We did not have that much time to spend with him because he was always in the ICU, and with my mother it was different. It was an ordinary ward and we were with her to spend time.
My father was also admitted in hospital for about 3 weeks in ICU, and he was not able to move, and he was having Parkinson. And that time, I think in the hospital there was no palliative care unit, and then the doctors did their level best. They did all the tracheostomy and other things, but it was very painful for my father. So frankly speaking, I didn't have much idea about the unit of pediatric care, and they told us all the things, what are the possibilities, because my mother was already very frail. But I feel that whatever stay my mother had in hospital, she was comfortable. So we could not see those kind of agonies or pain in her. So we were very satisfied.
As anywhere else, when you start something new, you always face resistance because people want to tread uncertainty carefully, and we did face it here. But important thing is the senior administration recognized the need because there were so many people who were suffering. So once we started palliative care, we critically looked at the patients who were at ICU, and our average length of stay, which was 15.2 days in the ICU, dropped to almost now 8.1 days. And this has significantly unclogged the ICUs. Patients who need to get routine ICU treatment are getting, and patients who shouldn't be there are getting palliative care. And this has helped the families also to manage their finances better because most of them are out of pocket spending, and also mitigated their suffering. So this was an aspect that administration appreciated a lot because it directly helped them to conduct their operations better.
In modern medicine, we take care of almost everything from preconception. So you have neonatology, you have pediatrics, then in the adult phase, there's a whole host of super specialties and specialties that are there. This palliative is the last stage, which has been somewhat lacking in the medical industry globally. That is one. And the second is, I feel if patient comes to your hospital, he should not be subject to pain. He should not suffer pain. As far as possible, no one should be suffering pain when they are in hands of professionals.
It is a teamwork. One has to understand that it is not one person who can do the palliative care. You need to have a doctor, a physiotherapist, a rehabilitation therapist, a palliative care nurse. It's a group of people who do the work of palliative care.
As an otolaryngologist, I have often dealt with a large number of head neck malignancies, and I've also, as an administrator, been part of the administrative setup. To me, it's extremely important that there is a high level of importance given to palliative care. Often we neglect this part of it. Pain of malignancy is often neglected.
The biggest challenge I feel is the awareness, and awareness not among the public so much, but awareness about the scope what palliative care does by the administrators of the various hospitals, because majority of the administrators think that palliative care is hand-holding and giving some morphine. They are unable to know the depth which palliative care provide and how much it could help them. And majority of the times this is brushed off by the administrators that this is not something that is important or not something that would provide them an economic gain and other things. And I feel that unless we have the specialty developing and demonstrating the scope, this would still be a major challenge that we would face. When we started in 2015, there were 300 cancer centers. Now we have 400 or 450. Creating the critical mass of cancer treatment centers with palliative care service, and they showing the other centers how integrated palliative care in a cancer center could change their practices. I think it still would be a challenge. And Lien Collab is doing that exact work in terms of creating that critical mass.